Okay, so Vijay sir, you can actually ask the residents manager here if they want to join. They can come and go through the very important part of.
Sir, sir.
So अभी हम शुरू करने लगे हैं. Can I have can I get myself a cup of coffee? Can I have like 1 minute?
Ji, of course. There's always time for coffee, madam.
Thank you, जी.
और प्लीज डियर हम सब के लिए भी कॉफी लेके आ जाएं.
मेरा ख्याल है this Zoom जो है ना ये organizers they should arrange for coffee for everybody.
Assalamu alaikum. Can everybody see my screen?
Ji, assalamu alaikum. Let's just see. Ji, perfect. So, Madam Amber, can you introduce us? Start the proceedings, and I think Vajat Sahab can say the salawat.
Sir, Madam Member has requested me, so I'll just start.
चलो ठीक है, आप कर ले, and then hand over the mic to Qurban Sahab for rest of the proceedings. ठीक है?
Okay. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل أعوذ برب الناس مالك الناس إله الناس من شر الوسواس الخناس الذي يوسوس في صدور الناس من الجنة والناس صدق الله العظيم. Bismillahirrahmanirrahim. I would like to welcome everyone to this session of Pakistan Cardic Society lecture series, which is an endeavor taken up by the Pakistan Cardic Society as a vision of President Pakistan Society, Professor Major General Suhail Aziz Sahab. Today's session will be the topic of electrical storm. Our speaker for today is Dr. Qurban Hussain, who is an electrophysiologist and cardiologist at Rawalpindi Institute of Cardiology and will be delivering this lecture. Our esteemed panelists include Professor Muhammad Shabir Saab, who is a cardiologist and electrophysiologist at the Armed Forces Institute of Cardiology, and Dr. Freya Sadiq, who is a cardiologist and electrophysiologist at Tabba Institute of Cardiology at Karachi. Our coordinators are Pakistan President Society, Professor Major General Suhail Aziz Saab, Professor Muhammad Hafizullah Saab, and Professor Amber Ashraf Saiba, and they have joined us as coordinators. I would request the speaker, Dr. Qurban Hussain, to please introduce his lecture and start with the proceedings.
Bismillah ar-Rahman ar-Rahim. Welcome to my talk. Today I'm going to be talking about electrical storm. I thank the academic committee of the Pakistan Cardiac Society for allowing me to give this talk, and I hope that everyone will gain something from it. Electrical storm. There's a picture of a bolt of lightning, and sometimes management of an electrical storm can feel like that. You're in the middle of a thunderstorm, an electric lightning storm, and you don't have much time to act. And making the right decisions in your mind early on can be the difference between effective and good management and being completely messed up and clueless. So what are we going to talk about today? Well, since most of you are FCPS cardiology trainees, I want you to come out of this lecture with an idea of what electrical storm is and how you manage it. You need to have confidence in treating it, and you need to know what your treatment options are. There will be MCQs where I'm going to assess some of the concepts. So I will signpost along the way key core concepts that you will need to internalize for the MCQs. So what is an electrical storm? It's a syndrome of recurrent episodes of sustained ventricular arrhythmia within a very short time frame. It's bad. It's associated with adverse outcomes. If you read 5 different papers, you'll have 5 different definitions of electrical storm. The most common accepted definition is 3 or more ventricular arrhythmia episodes within 24 hours. If you have an ICD, then 3 or more treated with shock episodes of ventricular arrhythmia within a period of 24 hours. Why does it matter? Quite frankly, electrical storm shortens your life. You have an increase in mortality. Even if you have 2 episodes occurring within the space of 3 months, it affects your mortality. There's a 3.3-fold increase in mortality compared with patients with no sustained ventricular arrhythmia. So it's very serious. What's the pathophysiology? It's the same pathophysiology as that of ventricular tachycardia. You need a substrate, you need a trigger, and you need autonomics. The most common substrate is a myocardial scar, although if you have a channelopathy, an arrhythmia syndrome, that's another type of substrate. Triggers can include ischemia, electrolyte and metabolic abnormalities, toxins, drugs such as QT prolonging drugs, hypoxia, hypovolemia as well. Anything that can disorder your physiology can act as a trigger. Autonomics, very important. Adrenal hypotonia, suppressed parasympathetic system. So either your parasympathetic system is suppressed, or more importantly, which is the most important aspect of this, is that you are in adrenal overdrive, sympathetic overactivation. I will repeat that terminology because it's going to come up again and again and again. Sympathetic overactivation. You can have the substrate, you can have the trigger, but you need sympathetic overactivation in order to go into electrical storm. And the way you tackle the management is tackling the sympathetic overactivation. So that's important to remember. Who gets it? Well, going back to triad, the substrate, you have either structural heart disease or a channelopathy. Triggers like electrical disturbances, ischemia, heart failure, sepsis, poor compliance, bradycardia. But sympathetic overactivation is very important. How do you present? Well, it's VT. So you can have patients with ICD or patients without ICD. VT can cause cerebral and cardiac hypoperfusion, so less blood going to your heart, less blood going to your brain, syncope, heart failure, cardiac arrest. If you have a device, repeated shocks or repeated anti-tachycardia pacing. What's anti-tachycardia pacing? Well, it's ventricular overdrive pacing, which is faster than the rate of the ventricular tachycardia, which is especially important if it's a slow ventricular tachycardia, and overdrive pacing is associated with less risk. You overdrive pace and you break the tachycardia. It's usually programmed into the ICD device before going for shock. How do you manage it? As always, pay attention to airway, breathing, circulation first. If the patient is unstable, go for advanced cardiac life support. If the patient has an ICD and it's shocking again and again and again, then you need to prevent this recurrent shock because it's associated with a lot of fear, anxiety, and obviously increased mortality as well. You need to look for triggers such as ischemia, electrolyte abnormalities. Most of the time, you don't really find these abnormalities unless it's very, very obvious. What about the ICD? What do you do? Well, if you're getting lots of VT and the rate of the VT is in range of the ICD shock algorithm, then the ICD will deliver shocks again and again and again. As I mentioned earlier, this is very distressing to the patient. They feel anxious, and if they're already in sympathetic overactivation, they will go further into sympathetic overactivation. And this is a vicious positive feedback cycle, which promotes and sustains ventricular arrhythmias. Now, shocks can be appropriate where you are getting ventricular arrhythmias and the shock is appropriate by the ICD, or inappropriate. The ICD thinks you have a VT, but actually it's a sinus tachycardia or an SVT or an atrial tachycardia, and it's shocking you anyway. Now, whether it's appropriate for a VA or inappropriate for an SVT, a shock will increase your morbidity and will definitely increase your mortality. So recurrent shocks are a bad thing. So what do you do? If you're in the ER or you're working and you're on duty, you must interrogate the device. if you can. If you've got a programmer handy, get the wand onto the patient's chest and interrogate. Interrogation allows you to confirm the diagnosis of electrical storm. You can exclude inappropriate shocks because you may have leads monitoring the morphology of the electrogram, and you can tell whether it's SVT or VT. If the morphology is exactly the same, then it's monomorphic VT. If it's different beat to beat, then it's polymorphic VT, or you may even see VF. It's very fast and a very disordered rhythm. And you can also reveal the mode of initiation of ventricular arrhythmia. Is it brought on by a PVC? That is very, very helpful when you think about the further management. So a device interrogation is absolutely essential if possible. Right? How do you reprogram? Okay, shock is bad. So if they are tolerating it, obviously if they're not tolerating it, you go straight for the ACLS protocol. But if they are tolerating it, they're managing their blood pressure, then you can disable shocks. You can prolong the detection time before the ICD gets into action, and you can program anti-tachycardia pacing given as the only therapy. Anti-tachycardia pacing does not increase mortality, unlike shocks. So you can also increase the number of ATP attempts before going for a shock, and this is to be encouraged. Some people may require all therapies to be switched off altogether, but then you need to have very good antiarrhythmic drug therapy so that you can suppress the VT before doing this. This is a diagram showing you four-pronged management of electrical storm. You may use all four measures. You may use all four arms of this, or you may use one, or you may use two, but usually you need 2 or 3. So antiarrhythmic drugs, starting at the bottom right-hand corner, so that means beta blockers and amiodarone usually, may include lidocaine or mexilatine. ICD reprogramming to reduce the number of shocks. Sedation or autonomic modulation. Sedation if ICD reprogramming and pharmacological blockade of the sympathetic nervous system has not worked, then sedation is the next step. Autonomic modulation, such as left cervical sympathetic denervation, epidural anesthesia, renal denervation, all these measures are used to modulate the autonomic nervous system. And if this fails, then ablation is now a class 1 indication in ischemic cardiomyopathy and a class 2 indication in non-ischemic cardiomyopathy, if all else fails. This is an algorithm talking about management of electrical storm. We've sort of gone over this before. If the patient is not hemodynamically stable, then ACLS protocol. If the patient is stable and has recurrent ICD shocks, disable the tachycardia therapy. You can also place a magnet over the device. This activates a reed switch in the device, and it turns off ventricular tachycardia and ventricular fibrillation therapies. You can change the programming so that the shocks are not delivered and anti-tachycardia pacing is favored. Okay, next stage of the ladder is beta blockade. You need to give as much beta blocker as you can. The 2 beta blockers of choice are propranolol and esmolol, IV esmolol. You need to identify potential triggers, whether they're hypoxia, hypovolemia, hypokalemia, hypocalcemia, hypomagnesemia. You need to go through all of that, or whether it's ischemia, worsening heart failure, sepsis, or bradycardia leading to torsade de pointes. If it's still ongoing, despite you addressing these issues, then you need to find out what the underlying cause is, whether it's ischemic cardiomyopathy or non-ischemic cardiomyopathy or channelopathy. So escalation of therapy at the bottom. Pharmacological therapies first line, beta blockers, amiodarone, sotalol, class 1A antiarrhythmic drugs such as quinidine, which is used in electrical storm due to Brugada syndrome. Procainamide has a role in structural heart disease associated with VT. Deep sedation, catheter ablation, neuroaxial modulation, ECMO. There is evidence for it, but it's a treatment of last resort. And then you've got LVADs and cardiac transplant if all else fails. Let's talk about each treatment step by step. Beta blockers are the cornerstone of management. They dampen sympathetic activation. They are either selective, such as metoprolol, which works only on beta 2 mainly, beta 2 receptors, or non-selective, such as propranolol, which works on beta 1 and beta 2. Now, as I mentioned before, esmolol and propranolol are best. Amiodarone, which is dose dependent. The greater the dose, the greater the suppression. You need to load, and I would advise that you load properly with 1 gram or 1.2 grams. It works synergistically with beta blockers. The effect is additive, very effective in the short term, but long-term usage is limited by adverse effects. Obviously, we all know about the thyroid effects, liver, lung, and autonomic neuropathy, and other types of neuropathy, and corneal deposits. These are all things that are problems with long-term use. We know that amiodarone increases the defibrillation threshold, which may make a shock ineffective. So that's something that you need to watch out for. What about lidocaine, mexilotine? They're class 1 agents. They block late sodium channel current. Mexilotine is an oral drug. Lidocaine is IV. Lidocaine is useful in terminating ventricular arrhythmias associated with myocardial ischemia, but not necessarily with healed myocardial infarction, which has caused a scar. There was a landmark trial in the year 2018 called the VANISH trial, which demonstrated that if you have a choice between catheter ablation and this is for patients who are already on amiodarone and beta blocker. If you have a choice between going for catheter ablation in these patients who are on amiodarone and beta blocker, or increasing antiarrhythmic drugs with adding with the addition of mexilotine, catheter ablation is superior to adding mexilotine. Remember, this is palliation. This is in order to reduce the burden of recurrent ventricular arrhythmias. This is just a slide talking about different management of different types of VT. So monomorphic VT, amiodarone, beta blockers, procainamide, because it's structural, lidocaine, and then the other measures, normal QT, lidocaine, polymorphic VT, which is with normal QT interval, lidocaine and amiodarone and beta blockers. If you've got a prolonged QT associated polymorphic VT, then isoproterenol, magnesium, replace potassium, and overdrive pacing. If you've got PVC initiated VF, then amiodarone and beta blockers, and then ablation to get rid of the PVC. And obviously in Brugada, that's slightly different. Isoproterenol and quinidine are used to treat electrical storm in Brugada. Okay, let's talk about deep sedation. This is effective because it works on the sympathetic drive. 47% of people with electrical storm have electrical storm termination within 15 minutes of commencement of deep sedation. This is very, very good, because if you have suppression of your electrical storm within 15 minutes, this is associated with a 55% lower risk of death. It's bad if you don't respond, but it's very good if you do respond within 15 minutes. Need to be aware also that sedative drugs may depress your myocardium further, especially if you have a reduced left ventricular ejection fraction to begin with. So this is a kind of diagram going through all of this, summing it up. There's an electrical storm, which is intractable. You start with your beta blockers and amiodarone. Doesn't work, go to sedation. If sedation, now this is the mortality chart for sedation, and red is no acute electrical storm termination, and blue is within 15 minutes or so. So mortality is much, much higher, almost double according to this graph after 30 days, if you undergo successful cardioversion using deep sedation. And if it doesn't work, then you need to consider hemodynamic support, IABP, which we have in Pakistan. LVAD we don't have in every institute. Neuroaxial modulation or urgent catheter ablation. Catheter ablation is class 1 for ischemic cardiomyopathy and class 2 for non-ischemic cardiomyopathy. Let's talk about catheter ablation for VT. Best chances of success in ischemic cardiomyopathy. More challenging in non-ischemic cardiomyopathy because the substrate is not always endocardial. Sometimes the substrate is in the epicardium. And as I mentioned, class 1 for prior myocardial infarction, class 2A for non-ischemic. The VANISH study, as we mentioned, patients taking amiodarone with ischemic cardiomyopathy and ventricular arrhythmias presenting with VT storm were far more likely to benefit from catheter ablation than escalation of antiarrhythmic drug therapy, in that case with mexilatine. Just a touch on autonomic modulation, thoracic epidural anesthesia, percutaneous stellate ganglion blockade in the neck. You use fluoroscopic or ultrasound guidance, and you inject a long-acting local anesthetic in the region of the stellate ganglion. You can undergo left cervical sympathetic denervation or renal sympathetic denervation, which can be done with radiofrequency ablation. If everything else fails, ECMO is a bridge to definitive treatment, such as transplant or catheter ablation. This is just a summary of everything I've talked about. If they're unstable, step 1, acute care. They're unstable, ACLS. Step 2, rhythm analysis. Supraventricular tachycardia on this side. If it's VT or VF, look for reversible causes. Start with amiodarone and beta blockers, procainamide sometimes, lidocaine if ischemia is ongoing. Deep sedation, intubation is the next step. And then if that doesn't work, then, you know, you've got options. You've got hemodynamic support, device programming, ATP probably should be higher up on this table. Autonomic modulation, thoracic epidural anesthesia, stellate ganglion blockade, that's SGB. High rate pacing for brady-mediated polymorphic VT, catheter ablation for structural heart disease, ischemic triggered polymorphic VT or monomorphic VT. Also, you've got catheter ablation for Brugada as well, which is an emerging modality and is a very effective treatment as well in electrical storm. Now let's go on to the MCQs. So I've signposted some of the important concepts. Hopefully the MCQs should be relatively straightforward. Let's start with its case history. A 55-year-old man with a history of ischemic cardiomyopathy, where his left ventricular ejection fraction is only 30%, presented to the emergency room with palpitations. His blood pressure was not hypotensive. His blood pressure was on the higher side, 155 by 99 millimeters of mercury. Oxygen saturation was normal, 98% on air. Respiratory rate was 22 per minute. Basically, he was not in respiratory or hemodynamic distress. His ECG showed a monomorphic VT, monomorphic, meaning scar-related. He has undergone DC cardioversion to sinus rhythms 6 times in the last hour, but each time has reverted to VT. So they're doing the correct thing. In any VT, DC cardioversion is always the correct therapy initially, but it's reverting to VT despite going into sinus rhythm initially. His labs are normal, meaning all his electrolytes and arterial blood gases are normal. Which option represents optimal pharmacological management? Is it A, IV amiodarone and oral mexilatine? Is it B, IV lidocaine and oral mexilatine? Is it C, IV esmolol and oral atenolol? Is it D, IV amiodarone and oral propranolol? Is it E, IV amiodarone and oral metoprolol? Let's give you 10 to 15 seconds and then we'll answer this question. Okay, let's get to the answer. The answer is B, which is wrong. The actual answer is D. The answer is D. IV amiodarone and oral propranolol. There's a mistake on the slide, but that's okay. Beta blockers work, tests are normal, so there's no obvious reversible cause for the VT. Beta blockers work by suppressing sympathetic drive. Propranolol is effective and has been shown to be superior than metoprolol Beta blocker is synergistic with IV amiodarone, which is a very effective short-term option in electrical storm, albeit one with several longer side effects. The answer is actually B. So it's not, the answer is given as B, but the answer is D. IV amiodarone and oral propranolol are ideal in this patient. Sorry for the mistake on the slide. Question 2. The same patient in question 1, ischemic cardiomyopathy plus electrical storm, remains in VT despite the ideal treatment with IV amiodarone and oral propranolol. Which of the following is the next best option? You've got A, ECMO, B, deep sedation, C, add sotalol, D, add quinidine, E, immediate ICD implant. Let's give you 10 seconds to think about that. So it's ischemic cardiomyopathy in electrical storm, given the ideal management of IV amiodarone and oral propranolol, which is the next best option. Give you 10 seconds for that. Which is the answer? Well, the answer is E. In this case, deep sedation. ECMO is a last resort. Sotalol should not be given with propranolol because it is pro-rhythmic with propranolol. Quinidine is an effective treatment for electrical storm associated with Brugada syndrome, but not in this case where it's structural heart disease and scar related. ICD implantation in this patient with electrical storm is inappropriate because the rhythm isn't yet controlled. And you would have a situation if you implanted the ICD where the patient would have uncontrollable ICD shocks. And this is the algorithm that you should know. So if you've got structural heart disease and you're in VT, class 1 indication is cardioversion. IV procainamide is also an option. Initially, initial management with IV amiodarone is not necessarily appropriate. If VT is terminated, then you treat the underlying disease, but if it's not, then you need to consider antiarrhythmic options. If antiarrhythmic options such as beta blockers and amiodarone don't work, then you need to consider sedation. And if sedation does not work, then the next stage is catheter ablation. Question 3. Same patient in question 2, the one with ischemic cardiomyopathy and electrical storm, who is treated with IV amiodarone and propranolol, is then put into deep sedation, but remains in VT. What should be the next step? Well, I've just gone over this, so it should be relatively straightforward. A is catheter ablation, B is ECMO, C is start calcium blocker, D is start digoxin, E is start mexilatine. Just give you 10 seconds for this. The answer is A, catheter ablation. Deep sedation and amiodarone plus beta blockade are ineffective, then you need to consider ablation. Ablation is superior than adding another antiarrhythmic drug like mexilatine, as proven in the VANISH study. ECMO is a last resort, and digoxin and calcium channel blocker are ineffective in scar-related VT. Last question. 66-year-old woman who underwent ICD implantation for ischemic cardiomyopathy 3 years ago, presents to the ER with a history of several shocks delivered by the device. ICD interrogation is performed, which reveals that 26 shocks were delivered by the device in the last 8 hours due to repeated episodes of VT. Which is the following best option? So multiple device shocks delivered because of multiple episodes of VT. So what are the options? Option A, increase the energy of the shocks delivered. B is decrease the energy of the shocks delivered. C is turn off shock therapies temporarily. D is only turn off anti-tachycardia pacing. And E is do not reprogram the device. Let's give you 15 seconds to work this out. What's the answer? The answer is C. So turn off the device shocks. Device shocks, whether they are appropriate for VT or inappropriate in the case of SVT, are associated with increased mortality. Shocks can be turned off, and anti-tachycardia pacing ATP can be relied upon to treat the VT along with pharmacological and electrophysiological management options. So you turn off the shocks, you focus on anti-tachycardia pacing, start IV amiodarone and propranolol, and then if that doesn't work, you think about catheter ablation. ATP anti-tachycardia pacing does not increase mortality in the same way shocks do. And that is the conclusion of the test. I hope you did well. I hope you picked something up from this. Thank you very much to all of the participants. And I'd like to turn over to the panel for any further discussion.
Electrical storm, as it says, is storm or, completely out of control activity, and which is electrical activity. So what I tell my trainees is, when you're looking at an electrical storm, obviously we're looking at a ventricular arrhythmia, which can be a ventricular tachycardia or ventricular fibrillation. And anything more than 2 episodes of treated arrhythmia by shock is called as electrical storm. So 1 in 24 hours is not. So definition we need to know. The important thing when we are dealing with an electrical storm is to categorize patients, whether this patient is having electrical storm spontaneously without having a device, or this is a device-related electrical storm. Because the pathophysiology, the etiology, and the treatment may vary based on what type of electrical storm you're dealing with, right? So electrical storm in patients who have a pre-existing intracardiac defibrillator versus a patient who comes in with electrical storm without a defibrillator. So your category is different, Ujjain. And understanding that ventricular arrhythmia happening in a patient without a defibrillator, we need to look at why is this happening. The first thing is, why is this happening? And because only when you know why is this happening, then you're going to be able to strategize your management plan. If this arrhythmia or electrical storm, which is repeated shocks within 24 hours or 2 or more, is happening in a patient who's having acute myocardial infarction, obviously you're going to treat myocardial infarction and you're going to help the patient with electrical storm. If this is happening in a patient who does not have an acute myocardial infarction and this is an inherited arrhythmia, you're going to treat accordingly if it's a young patient. If this is happening because of a device, then you need to understand why the device is going to be firing. It can be an appropriate device firing and it can be an inappropriate device firing. So before we start treating a patient, we need to know why and how and what is the reason, and then we plan accordingly. Obviously, once we have decided why is this happening, the etiology, then the strategy is geared toward it. There are certain management in the electrical storm that are kind of similar in both device-related and without device-related electrical storm. This may non-physiological, non-medical, or non-medication-wise planning is sedation, paralysis, all of that, balloon pump support versus medications. And medications made the top is are antiarrhythmics that we use beta blockers, and I'm going to just emphasize the role of beta blockers in electrical storm. A lot of times my fellows also ask me, why are you giving beta blocker to this patient? He's already in shock. Aapne balloon pump bhi dala hua hai. And I quote this study, jo esmolol or propranolol par aayi hai, propranolol pe. It reduces a sympathetic response and does not lower the blood pressure, and it helps in electrical storm. So the main drive is a sympathetic drive, just for humne kam karna hota hai. So the use of antiarrhythmics, beta blockers, non-pharmacological support, and if it's device related, then we need to know what is it appropriate device or is it inappropriate device related electrical storm.
So Dr. Faria, आपने समझा रही थी ना, so does it really make a difference if the VT is monomorphic or polymorphic when you're having a storming? Does that affect your thought process in any way?
So there's one thing that I keep telling my fellows, because this is geared towards making them understand arrhythmia. For us as electrophysiologists, and Shabir Sahab would agree with me that for us, VT and VF are two different animals. We treat VT as a separate entity, and we treat VF as a separate entity. Treatment does not mean that we're not gonna give amiodarone to one or shock the other one. We think about the etiology, the plan of management, and long-term risk stratifying them based on whether they had VT or VF. For us, VF is actually ischemia unless proven otherwise, right? So if there is VF happening, then this is ischemia. And we know that treating ischemia, mainly 90% of time it's ischemia-driven VF, it's gonna help. When we see VT, even if it is with an acute myocardial infarction, we think VT as a scar. So something, scar or dead tissue has already set in. So for us, VT should be treated with antiarrhythmics. If it's unstable, we shock. VF, we defibrillate. We give antiarrhythmics to keep them in the rhythm and prevent recurrent arrhythmia. And we treat the underlying etiology. But for us, when we see ventricular tachycardia in an LV dysfunction, pre-existing LV dysfunction, we think of a scar set in already, and on top of that, something else is happening. And treating that may not completely take away the trigger, or may take away the substrate. For VF, if we have acute MI, we treat and we know that's gonna settle the patient. So that's
Madam, if I could kindly, sorry to interrupt your very wonderful description. We, as physician cardiologists, not like non-EP cardiologists, treat VT as monomorphic, polymorphic. Does that affect your thought process that monomorphic is scar-related and polymorphic is ischemic? Although polymorphic tends to look like a VF. So when your description of VT versus VF, I mean,
yeah.
So how does monomorphic and polymorphic fit into this?
Very rightly. So as I said, VF and VT are two different animals. In VT, monomorphic VT and polymorphic VT are also two different animals. We categorize polymorphic VT with long QT or without long QT, right? That is very, very important to classify, because if polymorphic VT with long QT, we start thinking of all the triggers that have caused polymorphic VT. And polymorphic VT without long QT, we think of ischemia and equivalent to ventricular fibrillation. But when we see a monomorphic VT, we automatically start thinking of scar plus a trigger, which can be ischemia, heart failure, electrolytes, anything, but scar, which is actually the substrate. क्यों डॉक्टर शबीर आप अग्री करते हैं इस बात से?
So can I ask a question, please?
जी.
Dr. Free, in how many cases, I mean, we treat VT and we get more scared of VT storm because it leads to VF. In how many of cases, sorry, it may sound like a silly question, but in how many cases we have pure VF per se, or in how many cases we have VT degenerating into VF?
So VF, as I said, primarily is a arrhythmia of ischemia. And we know that if somebody has a VF, and I'm not talking about VF with a structurally normal heart, because that has a complete different etiology. So if we say bread and butter is MI, patient comes in with ischemia, has a completely occluded LAD, we know that once we treat that, we open that up within the window period, we're gonna save the myocardium and we're gonna prevent ischemia at the myocardial level, right? The sooner the artery is open, the myocardium is saved, VF arrested. But when we have a monomorphic VT, usually it means that the presentation is a little late. And if we have a MI, which is late presentation, and we open up the artery with a lot of complications like distal embolization and all of that, we know this is going to be an unstable patient in next 24 to 48 hours. I see a lot of arrhythmia with acute myocardial infarction at our hospital, and we know that patient presented 12 hours later with monomorphic VT, cardioverted, and they had an angioplasty, but distal embolization, complete Blashniaya. We know there is residual ischemia at the myocardial level, which may trigger the arrhythmia again and again. So we need to be on top of our game and make sure that once we've opened the artery, we give them a guideline-directed medical therapy as soon as possible to prevent the arrhythmia, because we are scared of that, not of just one VF presentation with acute myocardial infarction. I'm hoping I'm able to answer your question. And I'm
Yes, you are.
I think, I think the question remained unanswered. My question was, in how many cases of VF, they are the VFs which have been VT before and became VF later on? How many? Is it 25%? Is it 50%? If you see 100 cases of VF, how many of them started with VF and how many actually started with VT and degenerated to VF?
Well, I think I'm not sure कि मैं आपको exact इसकी percentage दे सकती
Just
हूँ.
roughly.
Visa, if I could interject here, if you persist with a VT, it's going to keep on getting ischemic. So every VT will degenerate into a VF and then a flat line. So the number of at which stage you catch these guys, because somebody has to drop before you take his ECG. It takes like maybe a few minutes before you can get a record of that. So this has to be different settings, like maybe there's some data on somebody already being monitored with a, let's say, a defibrillator which has a memory in it, or in a CCU setting. But in gen population would probably become very difficult data to find out. Certainly, I think I agree with Dr. Faria that this data is going to be very tricky. This number game is going to be very tricky, but eventually everything will go into a VF and a flat line. I'm not sure if that...
There are many patients who present with VTech, and they stay in VTech. We try oral drugs, and some of them come out. But there are people who will stay in VTech for maybe 12 hours, 24 hours, and they do not degenerate into VF. Maybe they are monomorphic, maybe they are otherwise more stable. But then there are other people who will come in VTech, and within seconds they will go into VF. So I was just trying to see how many.
That's a very, very relevant observation. In the meantime, I think Brady Shabir is here, and he is a very senior now FCPS. He's got 3 FCPSs, and he's an interventionist in AFIC. So Shabir Sahab, any comments on what the discussion going on right now?
Sir, आवाज आ रही है?
जी आ रही है आवाज.
अस्सलाम वालेकुम.
अस्सलाम वालेकुम.
अच्छा सर, ऐसा है कि जो सर का क्वेश्चन है कि कितने % एग्जैक्ट नंबर देना तो शायद पॉसिबल ना हो, लेकिन ब्रॉडली जो पेशेंट्स होते हैं स्कार रिलेटेड VT जिनका ओल्ड MI चल रहा है, they usually start with VTech and then go into VF. Acute ischemia, channelopathies, electrolytes, these are the patients who start with polymorphic VT and VF.
Okay.
So, any other questions, sir?
Can I answer one more question about General Suhail साहब ने ये कहा कि कुछ लोग VT में रहते हैं और कुछ लोग VT को VF में degenerate हो जाते हैं या so one thing which is important is when we look at patients और शबीर साहब भी agree करेंगे कि there are patients who have ventricular tachycardia at a very slower rate 110 120. These slower VTs, and they are VT, but the rate of VT is between 120, 130. They actually tolerate hemodynamically well. And they usually present with heart failure. And the reason behind slow VT is a larger area of circuit and a big scar. So इसलिए VT की cycle length जो है या VT का जो rate है वो slow हो जाता है, ठीक है? And those who have VT of more than 180 200 beats per minute, they degenerate or become unstable hemodynamically very quickly. So we do see patients who have VT at 120 and they present to us with heart failure. And they
sorry, Dr. Faria, ये slow and fast VTs का difference आप दोबारा बता सकती हैं ना? I couldn't really gather.
So VT, when we say VT is a monomorphic VT, and we define the monomorphic rate क्या है? 150 का rate है, 160 का rate, 180, 200. So the monomorphic VT can present with variable rates, right? So for us, if somebody has a slow VT at 120, 110, 100, 130 beats per minute, this to us as electrophysiologists means there's a huge burden of scar, and the re-entry of that monomorphic VT, and I'm using the word re-entry, which is the electrical mechanism of arrhythmia. So it's a re-entrant mechanism in a scar, and the bigger the scar, the slower the VT rate will be, and usually they tolerate arrhythmia, but they present with heart failure and not with arrest. Those who have VT of 200 beats per minute or faster, this means that this is usually a smaller area of scar superimposed with a trigger, which can be ischemia or electrolytes, and they become unstable. I'm hoping the audience is able to understand VT fast and slow rates. When somebody has a VT of 200 beats per minute, they usually become unstable. It is very difficult to overdrive them and pace terminate them with a temporary wire, as we call in our device terminology, anti-tachycardia pacing. They need shock, cardioversion. VT with a slower rate, monomorphic VT with a slower rate, 110, 120, 130, 140, we are able to overdrive and treat them without shock. So this is how it is, and slower the VT means larger area of scarred, almost dead tissue. And
that's really wonderful. That's very well explained. Thank you very much.
So there's a question by the audience.
Can I just add one more thing for the trainees is that we emphasize on using antiarrhythmics, amiodarone as per ACLS is the first line, but we are actually underestimating the effect of IV lidocaine, which actually works very well with the ischemic myocardium. If you look at its the efficacy in ischemic myocardium, so IV lidocaine works very well in ischemia. And a combination of amiodarone, IV lidocaine, and oral propranolol works very well. And as Qurban had suggested that once the combination of antiarrhythmics is not working, and patient keeps going into ventricular arrhythmia, if it is a monomorphic VT with a stable heart rate without hemodynamic instability, before you shock, you can try overdrive pacing by putting in a temporary wire and start overdriving. Then the other thing that he's already mentioned is sedate, paralyze, intubation. And in addition to that, although there's a very limited data on the intra-aortic balloon pump, and a lot of studies promote ECMO, or LVAD, intra-aortic balloon pump also helps in electrical storm. Though the data is limited, and in Pakistan we only have IABP, right, intra-aortic balloon pump, so we can use that as well.
Sorry to the question by the attendees, which is like with the panelists. Patients with underlying LV dysfunction and recurrent VT episodes, what's the long-term use of propranolol in such patients? Can it be co-prescribed with bisoprolol or carvedilol? Some of the questions.
It's always the underlying how patient behaves. Like if patient is responding well to beta blockers, that's the first line. If beta blockers are not working, then we can add imidazole and other antiarrhythmics also. One thing I would like to add, or here we are missing, that is, if we are talking about scar-related VTs mostly, but what if patient is having underlying channelopathies like Brugada syndrome, long QT, the treatment plan would be entirely different in that case. Then we have to go like Brugada, we have to start with acetylcholine, even is very effective. We should look into the underlying cause first and then proceed. If patient is having
So we talked about oral propranolol in the acute setting. How about IV metoprolol? Because metoprolol was supposed to be more antiarrhythmic. And most of these people have lowish blood pressure. It's a reduced ejection fraction.
Esmolol, propranolol, or metoprolol, IV in case of acute settings, not oral.
No, we're talking about acute study in the setting of ventricular analytical storm.
In acute, always
Before we answer that, I think the answer to the audience has not been given so far about combining.
Can I answer the audience question? So if somebody has LV dysfunction and recurrent VT episodes, the use of propranolol that is being encouraged is in acute setting, in electrical storm, and the purpose of propranolol is to reduce the sympathetic drive, as we keep talking about reducing the sympathetic drive. So it does not reduce the blood pressure as metoprolol or bisoprolol or carvedilol will do. So we're not using beta blocker as per se as beta blocker. We're reducing the sympathetic drive and using propranolol. Once we are out of electrical storm, the use of bisoprolol or carvedilol for LV dysfunction would remain the mainstay long-term management as we would do for any other patients. The only purpose of using propranolol or IV esmolol, as the studies have done, is to reduce the sympathetic drive. You know, as I previously mentioned, a lot of trainees would fear using propranolol, saying the pressure is low, patient is on IV norepinephrine, epinephrine. So the purpose of propranolol is to reduce the sympathetic drive, and propranolol is much, much, much better than metoprolol for that purpose. So acute setting, propranolol, reduce the sympathetic drive. Once the patient is out of that acute setting, treat the patient guideline-directed medical therapy, bisoprolol and carvedilol for LV dysfunction as we do for other patients. I hope I have answered the audience question.
Yes, you have, Dr. Faria, but one little comment that the fear that with that high dosage, the blood pressure is going to fall, especially in a poor LV, that seems to be genuine. So although you're getting that sympathetic blockade, how do you address that other part of the question that it will drop the blood pressure and the concerns of the treating doctor about falling blood pressure with beta blocker?
If you, so people who use propranolol regularly for electrical storm, and they have a lot, and with the data support, that you do not see a lot of blood pressure drop with propranolol, fortunately, which actually helps us treating these patients. So we don't
So
see
can
a
you
lot of blood pressure.
can inotropic support to these guys if their blood pressure
Yes.
drops? So would that counter your?
Yes, with inotropic support, you use propranolol, and you may not see a blood pressure drop. That's what the purpose of propranolol is. It does not reduce a lot of blood pressure. It can be used on inotropic support with intra-aortic balloon pump to reduce the sympathetic drive.
Further to this, we see people with ventricular ectopies which have changing frequencies, and people traditionally we would give Inderol and propranolol. Can these be given, guys, be given Castle or metoprolol or bisoprolol, or is Inderol superior to these guys who get these symptomatic ventricular ectopies? Purely for the reason of sympathetic overdrive.
Okay, so ventricular ectopy per se is a totally different ball game, right? Ventricular ectopy in structurally normal heart versus ventricular ectopy in structurally abnormal heart. Structurally normal heart, the first medication that we use is beta blockers or calcium channel blockers to reduce the frequency. But we need to understand that beta blockers and calcium channel blockers will only work on a ventricular ectopy in a structurally normal heart, which is calcium channel blocker or beta blocker dependent, right? So so it is important to classify how the ectopy is happening, and for an electrophysiologist, most of the time when I see a lot of ectopy symptomatic high burden in a structurally normal heart, I may not want to start with a beta blocker or calcium channel blocker, and thus one antiarrhythmic may serve the purpose of reducing ectopy without affecting the sinus node overall. So it is important that what type of patient you are actually dealing with ventricular ectopy.
Okay.
Can I? Sorry. Can I ask a question, please?
Of course, sir, you can.
Cortisone has been painted as a very unfriendly drug with lots and lots of side effects. But you use it a lot more, and we have been using it as well. I think if you use it in smaller dosage, it's a very friendly drug. If you keep an eye on the side effects profile, you can use it very nicely in a small dose. I mean, 100 milligram dose, and it is an absolutely wonderful friend, especially in difficult cases like people with cardiomyopathy with elevate depressed function and PVCs and history of VTEX. And I would like to hear from the horse's mouth, what do you think about it?
Let's say hear from the expert's mouth, sir.
Well, I mean, she has got different animals for different, so I thought, let me put it now. We have got different animals as doctors as well. Cardiologists are two types of different animals, electrophysiologists and then plumbers. So that's why.
I think the way you put it, Shabir Saab and Qurban will respond, but Madam Faria certainly would not.
She would definitely. She understands.
So anybody can take that question.
I'd like to talk about my limited experience with amiodarone. Where I've worked in my career, our departments have been very, very conservative with amiodarone dosages. And we've obviously monitored people every 6 months or 3 months, thyroid function, liver function, chest x-rays, pulmonary function tests, and also eye examinations. Corneal deposits are very common. 80 or 90% of people have them. So you can't, it's sometimes difficult. You can't really reduce the incidence of that. But in terms of liver, thyroid, peripheral neuropathy, and other side effects, I've had very few. But in our department in AFIC, our policy was to bring the patient down to in some cases 100 milligrams a day, or sometimes 50 milligrams a day. I don't know how often that's practiced in other departments, but we didn't have the large percentage of patients with side effects that I initially had expected.
So may I share some data on it? So amiodarone is a good drug. As Dr. Fizola said, it's very friendly. We need to understand why are we giving this if it's being given for atrial arrhythmia or if it's being given for ventricular arrhythmia. The loading dose for atrial fibrillation and loading dose for ventricular arrhythmia are different. Maintenance dose for atrial fibrillation and maintenance dose for ventricular arrhythmia are different. We also need to understand the pharmacodynamics of the drug, that it is protein bound. So you don't have to use this drug for the rest of the patient's life. You can use it for short-term bursts, like 3 months. So I'm not going to share my experience, but I'm just going to share the data from the trials, is that if you give stop and reassess the patient's symptoms, you may actually, not have to give this drug for continuous and give them in burst. 3 to 6 months, stop, reassess, may reinitiate, and then start and stop. And the doses is defined on what type of ventricular arrhythmia you're dealing with. So that's what my take is on amiodarone. Unfortunately, we don't have many other options in Pakistan for antiarrhythmics. Yeah. Mexiletine is also a good drug for ventricular arrhythmia management. And other than that, if somebody has ventricular arrhythmia and drug refractory like amiodarone or lidocaine, one of the trainees have asked a question on ablation. Yes, ablation of ventricular arrhythmia is possible, but this is a palliative ablation, understanding that we're not going to cure the arrhythmia, we're just going to reduce the burden of arrhythmia with ablation. And that's what the purpose of drugs and also ablation is, to reduce the burden. We cannot take away the scar in a cardiomyopathy.
There's a question from the audience. Dr. Majad, can you put it across, please?
Yes, sir. There's a question by Dr. Irfan, who's asking, does optimization of the heart rate improve the LV filling pressures and blood pressures?
I think so. What was being asked is, does persistent tachycardia affect the ejection fraction and the heart function? Would that be right?
Yeah. And the second question was about ablation that Madam Freya has answered. That I think that's been answered. This is a question about heart failure and LV filling pressures, optimization of heart rate and their role in it. That was the question.
I would like to just add something about ablation. Madam Dr. Freha mentioned a scar and scar-related VT. Not all VTs are created equal. Ischemic cardiomyopathy, if you go through the algorithm where you treat medically with beta blockers, amiodarone, you go for sedation, you try other antiarrhythmic options. Ablation is a class 1 indication for ischemic cardiomyopathy, but it's a class 2 indication for non-ischemic cardiomyopathy, and that's related to ablation. You may need to go for an epicardial approach, which is not always feasible. So, and it's a very technically demanding and difficult procedure to ablate a non-ischemic cardiomyopathy, and chances of being arrhythmia-free at the end of 1 year are somewhere between 50 and 60%. Whereas being arrhythmia-free in ischemic cardiomyopathy post-ablation, your chances are around 70, 75%. So ablation is a viable option in centers that have high volume. And ischemic cardiomyopathy ablation is has a better results than non-ischemic cardiomyopathy. I hope that answered.
Thank you, Qurban. Just did not wanted to give the audience a message that VT ablation is curative. VT ablation in LV dysfunction is not curative. It is palliative. And yes, you offer VT ablation, and trials have shown drugs versus ablation that they both fare better, and it is used to reduce the frequency of arrhythmia, especially in patients who have ICD and they keep having ICD treatments. So it is a palliative option when they are drug refractory. But if we are treating ventricular tachycardia with catheter ablation in a structurally normal heart with no scar, no LGE on CMR, that's almost curative. Like fascicular VT, RV. VT, like LV, track VT. So that's a totally different dysfunction is usually ablation, drug refractory.
Patients, just a question, who have ectopy, atrial or ventricular, and otherwise structurally normal heart, how do these guys fare in the long term? Anyone can answer that? Anyone of the panelists?
Yeah, I think we all know about it, and we're not, but we have been dealing with it for a long time before the electrophysiologist era, and we had lots of. I can remember lots of my friends, physicians who came from UK under pressure, under a lot of tension, and they used to have lots of ectopics, and we used to treat at that time with beta blockers and sometimes with calcium antagonists, and all of them went through the phase and they improved, and they do not look back at all. They do not look any drugs. So I think probably this is a benign phenomena and perhaps do not have any sequelae as such.
I think I was reading some data that patients who tend to have atrial and ventricular ectopy tend to have long-term, things happening in their LV function. And another thing I've noticed is that if you ablate, let's say, somebody with a SVT, in the follow-ups, none of them do well, but more of them tend to have vasovagal symptoms and different, they continue to happen. So my take was that there's not just one aberrant pathway which has to be ablated. Okay, somebody's mic needs to be off. There's something happening here. So these people who tend to be ablated, a lot of them do well, but a lot of them seem to continue with their symptomatology in different shots. So what's your experience, Qurban Saab, Dr. Faria, and Shabir Saab, about these two aspects of ventricular ectopy and ablation?
Sir, can I answer the first part of the query? I think there is electrophysiologists think about ablating when a patient has recurrent and symptomatic ventricular ectopy. Definitely, the data shows that if you have a PVC burden, premature ventricular complex burden of more than 20%, then you are at risk of developing left ventricular dysfunction. So certainly, most departments go for ablation in a structurally normal heart, where you have, let's say, for instance, right ventricular outflow tract origin PVC, or left ventricular outflow tract origin PVC, or a normal, structurally normal heart. Most departments would go for ablation beyond a limit of 20%. In other countries, people ablate even at a 10%. So the PVC burden is very important. The rest, in terms of atrial ectopy, and I think a lot of that is down to, is it controlled pharmacologically? Is there symptom control achieved? How is it affecting the patient's life? And most of us, most doctors, I think, would treat something that's really affecting people. I wonder what the other panelists would like to say about that.
A comment about this, Dr. Qurban sir.
I agree with Qurban's.
I came across quite a few patients who were very symptomatic.
Assalamu alaikum. Just a quick question for the great panels that we are having. I'm enjoying the discussion, but probably I have to go push off. So I just wanted to ask a quick question. In preventive cardiology, you have got a lot of things being discussed. Those who have got electrophysiological problems, is there a preventive part of it? Because we have this all amiodarone issue that people keep on taking it regularly. So what is your take on that?
Okay, so,
which means, can we allow the general cardiologist to prescribe amiodarone? Can we allow general cardiologists to use amiodarone in small dose, and for how long? Same as my question.
Okay, so for prevention of VTBF, if somebody has never had an arrhythmia, I don't think there is any guidelines saying empiric use of amiodarone or any other antiarrhythmic for that purpose. Obviously, we have a huge armamentarium of the drugs that actually help the LV myocardium, and use of ARNI, beta blockers, aldactone. All of these drugs will remodel the ventricle and reduce the burden of arrhythmia and prevent ventricular arrhythmia. But when we talk about secondary prevention, use of long-term antiarrhythmics is not recommended. As I said, the side effects of the antiarrhythmics are huge, whether it is dronedarone, amiodarone, mexilidine, whatever. So you can use these drugs for short durations and then stop. You should not continue this indefinitely for preventing of arrhythmia. So that's should be the message. Well, if you do aggressive guideline-directed medical therapy and post revas, you help LV remodel, the risk of arrhythmia will get better. But once we have ventricular arrhythmia and we are using antiarrhythmics, it should not be indefinitely.
Okay, that
you
was
say that it should not be. So when you say that it should not be indefinitely, so when you say it should not be indefinitely, what do you mean? That let us say the patient has not had a symptom for, let's say, 6 months. Is that the time to start weaning, or do you want to wait for 2 years before you start weaning to stop? So that is what everyone wants to know.
I think 3 to 6 months of antiarrhythmic drugs and stop and reassess is actually is a better way. Understanding the pharmacodynamics of amiodarone is protein bound. So once you stop, it's still not excreted out of the body, and the plateau dose still remains in the body. So it's protein bound, and it still stays in the body for that half-life. So if you stop amiodarone, it's not out of the system completely immediately the next day. So so a lot of electrophysiologists would practice short bursts, 3 to 6 months, stop, reassess, stop, reassess. That's what the recommendations are.
So
right. And one other quick question is regarding the young ladies who want to have children. So at what time can we say that now it is safe for you to go ahead?
I'm sorry, I didn't get the question, Dr. Bilal.
Another question is regarding the young ladies. When can they start having a family?
Pregnancy.
Pregnancy related, you know, when can they start having? I hope you can hear me. Pregnancy and...
Can somebody conceive while being on these drugs?
Well, all these antiarrhythmic drugs are class X. You should not be using these drugs while they are pregnancy. The only drug that have shown some safety when they're using for arrhythmia is sotalol. So patients, the women can have pregnancy and they can use sotalol while they are pregnant, and we have data to support use of sotalol, and it's not class X.
Okay, for those of you wonderful people who don't know, that voice in the dark was from Professor Bilal Muhyiddin, the Secretary General of Cardic Society, who, thank you for joining us, Bilal. Just a little comment that there be data that people with very frequent VPCs tend to have a higher pro-BNP. So that is one aspect, and some of the people use that as a barometer for ablation for these patients. Now, I wonder if any comments are there on this aspect, and I think we overshot the time. So any quick comments, and then we can probably wrap up the session.
I think just one message to take home. So I think what Faria explained very nicely, and what the message for the general cardiologist should be, that we can use Cordaron in a small dose for a specific period of time. There's perhaps, I think probably 3 months is a very good period of time. And whenever somebody is on for Cordaron for 3 months, stop or at least reassess. And we must not continue it for lifelong as such. And when we are using 100 milligram, we should not feel terribly under pressure that we have to stop the drug. As I say, it's a wonderful drug, especially for people with recurrent AFs or people with PVCs, which is bothersome. So in that sort of a setting, I think probably Faria has given us a very limited controlled license to use it in small dose, that is 50 to 100 milligram for 3 months before we can refer it to the electrophysiologist. I hope I'm correct, Faria.
You have actually taken liberty of extending your own thought process and place that on Dr. Faria's shoulder. But I think that's a good practice. So any comments, Dr. Faria, Dr. Shabir, Dr. Qurban, and then we wrap up?
Well, my shoulders are burdened with that holding the license to for the cardiologist. I think my only message is that electrophysiologists are extension of general cardiologists. Where you stop, we start. So when you feel that you are unable to manage, or a patient needs more than medications, please do refer to electrophysiologist.
Exactly.
And we may be able to help you guys.
Dr. Shabir? Or Dr. Qurban sir?
I'd just like to summarize what I think a trainee in general cardiology should get from this presentation and the discussion as well, particularly regarding electrical storm. I think that every trainee should have in their mind that electrical storm is exacerbated by sympathetic overactivation, and every step that they should take should reduce that sympathetic overactivation, whether that's giving amiodarone IV, beta blocker, sedation. Just have that in your mind if you're a trainee and you see this, and don't panic. And the other message is, I'd like every person during their cardiology training to know how to use a magnet and also how to use a programmer, so that if they're faced with a situation with a patient who is well away from an electrophysiological department, having multiple ICD discharges, which is a very, very scary situation for patient and doctor. I hope that people during their training learn how to switch therapies off, or at least know how to, know how to use the programmer, phone somebody, get advice. Those are the two things that I want general cardiology trainees to get from this.
I think that's a great advice, and I think we should all teach our trainees how to, use these programmers. And I think today what I realized was that maybe we should record these lectures beforehand, so in case of internet interruptions, we can continue to go through the lecture, then have a question and answer session later. We can see Bilal Sahab sitting there. Bilal Sahab, any quick comment? Quick comment is a quick comment, of course, and then Bilal, we ask Vijala Saab to wrap up the session for us.
Indeed, a great save and a great, well done discussion on VT. We were looking forward to a lovely PowerPoint presentation, but I think the real crux of coming up and giving an idea of how to be managed, that is that one which needed to be emphasized. And special thanks to Dr. Faria for what a lovely way of going about in an extempo fashion. And Qurban Saab, inshallah, we'll be listening to you again very shortly. It is indeed a pleasure to know that everyone is on their toes, trying to do the best for the country. With all that said, I say Pakistan Zindabad.
Professor Vijala Saab?
Yeah, I think you're all very grateful to Faria, whose shoulders were first of all burdened by you, by putting her on spot and to make her give a talk impromptu, and she did a wonderful job. Thank you very much. And I think even this is perhaps a very good way of communication and a very good way of disseminating the knowledge. And I think those pearls of wisdom which were shed wisely, which picked up by a lot of people. And I think this electrical storm, I remember, standing next to the patient and petrified before the EPs would come in. This I'm talking about when I was young. And it is really a petrifying experience. So I'm very happy that Qurban took over this subject and enlightened us and made us aware that, there is a lot of options which we did not know at that time. I mean, we would be thinking about giving Lidocaine, Amiodarone, looking for magnesium, running around like scalded cats and trying to correct potassium, but there are other options. And I'm very grateful for providing this forum with these pearls of wisdom that we have learned from all of you. Excellent job, Dr. Qurban, Dr. Shabir, and Dr. Faria. Special thanks to you. And I'm sure we'll keep burdening your shoulders with more responsibilities. Thank you.
Great.
You,
Thank
Dr.
you very
Bilal
much, everybody.
And Dr. Fizola for those kind words. I'm really, really honored. Thank you.